from the University of Kansas Health System.
I am amazed. The team here is great.
I came on a Tuesday, and then by Saturday I had a heart in me.
I have never seen a group of people work together so good as this team of heart specialists. I mean, it's just unreal.
Stand by to set up show.
And the Dolph C. Simons Jr. Family Broadcast Studio.
Roll it.
Always makes you feel like you're the most important patient on the planet.
I felt heard, and that was really big.
This is All Things Heart.
Good morning, I'm Jessica Lovell in for Alexis Del Cid this morning. Welcome back to All Things Heart. When Mark-Ann Barton was diagnosed with a genetic heart condition, she thought of her dad. His heart stopped at just age 30 when Mark-Ann was just a toddler. It made her then wonder, was she at risk of an early death too? And what would this new diagnosis mean for her 3 children? Here's Janine Keesley.
It was a terrifying diagnosis. Mark-Ann Barton was a new mother with triplets who weren't even 2. She armed herself with knowledge to find the right doctor for her, and that brought her here to the University of Kansas Health System.
My initial explanation was you hear of those athletes that are in phenomenal condition and they're on the basketball court and then they just drop dead.
At the time, Mark-Ann had triplet toddlers at home, and she was terrified. She didn't want her children to lose their mother like she lost her father decades earlier.
But then when I was diagnosed, and it is a genetic heart condition, looking at my family history, one of the outcomes is sudden death.
Hypertrophic cardiomyopathy, or HCM, is a condition in which the heart muscle becomes abnormally thick, making it hard for the heart to pump blood.
Very simple.
An implantable cardioverter defibrillator, or ICD, can jolt your heart back to normal rhythm.
Just pick it up and then put it on your device.
Mark-Ann got such a device not long after her diagnosis.
And then it sends basically a report to the doctor's office.
Then she was on a mission to find the perfect doctor to treat her. Dr. Berenbaum at the University of Kansas Health System was the perfect fit.
I feel incredibly grateful. Dr. Berenbaum is very detailed-oriented.
The first thing Dr. Berenbaum did was getting Mark-Ann tested to see if she carried the gene for HCM. She did. Unfortunately, her triplets also have the gene. When they turned 16, they all started seeing Dr. Berenbaum, and despite living on opposite coasts, they remain under his care. Mark-Ann wouldn't have it any other way.
I've been fortunate to have Dr. Berenbaum as my doctor through this, and I feel that he has our best interest at heart.
And we are so pleased to welcome Mark-Ann Barton to our program today, along with her doctor, Dr. Lauren Berenbaum. Dr. Berenbaum is an electrophysiologist and cardiologist here at the health system. Welcome to both of you. Thanks for being here.
Good morning.
Thank you.
So, Mark-Ann, you were diagnosed when your children were just 2 years old. What symptoms were you having?
Yes, well, I actually had a sore throat, so I went to the doctor, and at that visit, the doctor detected a heart murmur, which led to further testing that revealed I had hypertrophic cardiomyopathy.
What were you thinking when you heard that diagnosis?
I was, definitely fearful, and was not, due to the fact that my father died suddenly at a young age. That same thought came to my mind, and having 3 young toddlers, so the fear set in. But I was on a mission to, find out what would be the best care and the best doctor.
I hear you. It's like you're going to mom mode. You got to be around for the kids. So it's a lot to take on. Dr. Berenbaum, we heard a little bit in the video about what hypertrophic cardiomyopathy is. Big word. How else might you explain it?
So hypertrophic cardiomyopathy is an abnormal thickening of part or all of the heart muscle. And the most classic kind, which is what we are talking about today, is what's called the basal septum, which is the part of the heart between the 2 lower chambers, the right ventricle and the left ventricle. And when that part thickens, that can lead to obstruction of flow out of the heart. The heart actually gets in its own way as it contracts and tries to pump blood. Blood can't get out normally. That puts the heart under increased stress.
So it's genetic. How does it get passed down?
So it is what's called, in almost all cases, it is autosomal dominant, which means you get one gene copy of the gene and you'll have the disease. Or at least you have the genetic predisposition to the disease. There are other diseases that are autosomal recessive, which means you need a copy of the gene from mom and a copy of the gene from dad in order to have the disease.
This is called All Things Heart, so we hear about all types of heart issues. What makes this particular diagnosis so dangerous?
You know, I think we've come to understand, I've been doing this for a few decades now, and I think as our diagnostic tools have gotten better and our understanding of the disease has gotten better, it's actually not nearly as dangerous a disease as we thought a few decades ago. And a lot of that is because we have better treatments for the disease. But you know, when you have a headline of a 22-year-old basketball player going down court and suddenly collapsing and dropping dead, that gets a lot of attention. And that, you know what, the 1,000 people with HCM who are doing well and leading pretty normal day-to-day lives, that doesn't make headlines. And I would say at this point, the vast majority of people with HCM are going to live a long life and die of something else.
That is good news.
Yes, it is.
To talk about when we are talking about something so serious. And Mark Ann, you mentioned your father died when you were just 2 years old. And before the program started, we were talking about, you mentioned decades, what we knew about this, 2 or 3 decades ago when your father passed away, very different. How would it have been diagnosed back then?
When I started in cardiology, we had what's called an M-mode echo, which basically was kind of like looking through a tiny little telescope and seeing one tiny little bit of the heart, not really being able to get a good overall view of the heart. Then came 2D echo. In the last couple of decades, cardiac MRI has taken a big role in diagnosing HCM. And these tools allow us to be much more specific in making a diagnosis, much more sensitive in making a diagnosis. We also use genetic testing. Now, there are 30 to 40% of people who have HCM don't have an abnormal gene that we have found. Doesn't mean it's not genetic, but we don't have their gene. But about 2/3 of families, we do get a positive genetic result. And that's very helpful because that allows us to then, for instance, with your kids, be able to do genetic testing on them and saying, you don't have the gene, you're not at risk, you don't need to worry about this, and neither do your kids and grandkids. Or you do have the gene, and we need to pay attention.
So, Mark Ann, I know you've talked to your children about this over the years because it could have affected them, and it does. So, growing up, what did you hear about how your father had passed away? What information were you being told back then?
Well, back then, which was, quite a while back, they didn't really have availability to echo and MRI. So he was not actually diagnosed with HCM. So he died suddenly, while jogging on the LSU track. So of sudden cardiac arrest. Basically, he had rheumatic fever as a child, which weakened his heart. So my mother just assumed, he, just had a weak heart, and that's why he had sudden cardiac arrest. But then HCM is an inherited disease, And when I was diagnosed, you know, we looked at my mom's history and my dad's history, and it was evident that it came from my dad's side of the family.
So what age do people usually get diagnosed with this?
So there are cases that present in childhood, but I'm an adult cardiologist, so I don't see those, although I hear about them rarely. But most of the time, this is a disease that manifests after puberty, and most classically in the first decade after puberty. But sometimes when you're 40 or 50 or 60 or 70, and you know, there are a significant number of gene-positive individuals who never manifest disease.
You brought us a couple of videos that I want to take a look at. This is Kate. This is Mark-Ann's daughter's heart. What are we seeing here?
So this is what we call a two-dimensional echocardiogram. We're basically taking a slice through the heart. Mm-hmm. That is the left atrium, okay, the left upper chamber of the heart. That's the mitral valve.
Opening and closing.
Opening
See that?
and closing. This is the left ventricle. This is the right ventricle. This is the interventricular septum. And if you look at this area here, that's the basal septum. It's thin, it's normal, it's the same thickness as the rest of the heart. And when we get to mom's echo, we'll see it looks a little different.
Okay.
And this is mom's echo. Mm-hmm. So you can see that this part of the heart muscle is much thicker than on the last echo.
So can we go back to Kate's? Sure. Yeah, very thin. That flap that keeps coming.
Again, it thickens as the heart contracts. That's normal. So you see it when the heart is filling and the heart muscle's relaxing. That's very thin. And then as the heart thickens, it does get thicker. That's normal. But we're looking at the minimal thickness when it's relaxed. And this, unfortunately, this septum is twice the size of a normal septum, basically.
So Mark-Ann received an implantable cardioverter defibrillator, an ICD. What does that mean and what does that do?
So basically, that is life insurance. Not life insurance in the sense that if somebody dies, someone else gets a check, but rather life insurance in the sense that if you were to have a sudden, unpredictable, life-threatening arrhythmia, that device would recognize it within a few seconds, and then it would either pace her back to a normal rhythm or deliver an electric shock to shock her back to a normal rhythm. And it would be a minor event instead of what it would most likely be a life
catastrophic
event.
Mark-Ann, what was surgery like?
So it was a same-day procedure, and basically they make an incision like above the chest, and they implant the ICD under the skin, and it's kind of like on the side of the chest below the armpit. And then there's leads that connect, there's wires that connect the leads that advance to the heart.
And we saw you in that video holding something up to your chest. Does that communicate?
That's actually a remote monitoring device that I have at home. So I will go routinely in for cardiologist visits at University of Kansas Health System, and they will do a device check there, and they may also do an echo, and then I'll have a doctor visit. But I also have a remote monitoring link that's at home at my bedside that, like I'm not sure how often, but it will interrogate my device. The video showed me manually interrogating the device. So if it accidentally got unplugged and they didn't get a reading, they would contact me and let me know, and they would have me manually interrogate my device.
So Dr. Berenbaum, what are you hoping to get from that data that gets sent back to you?
So that tells us a lot about her heart rate and her heart rhythm, if she is having abnormal rhythms in the upper or lower chambers of the heart. And this device basically treats the fast abnormal rhythms in the lower chambers of the heart, but it can help us detect and diagnose other kinds of arrhythmias. And then it tells us if she's had any therapy for the device, which in 24 years so far, this remains what we call a primary prevention device. It's there in case an event happens, and so far.
Yeah, you can knock on that wood.
Yes.
I'll do it too.
In cases.
Well, what a peace of mind, Mark-Ann, that must be.
Yeah, absolutely. I feel like the benefits far outweigh the risks.
Can you feel it inside? What does it feel like to have that device inside?
I've had it, you basically, originally when I had my first implant at age 33, and the battery life was probably about 5 years back then, but now it can be up to 10 years. So I've had new ICDs, over the years, like my ICD replaced. And you can feel it. As far as seeing it, there's a slight bulge, and you can feel like the outline of the device under your skin.
So all three of your children, your triplets, all inherited the gene. How old were they when you found out?
Andrew, my son Andrew, was actually diagnosed at age 10 because he actually had presentation of the disease. And then at age 12, genetic testing came available, and Dr. Berenbaum suggested, they all get genetically tested. And at that point, it confirmed that they all have the genetic marker.
Okay, those are some gorgeous children. Very darling children. What a scary time as a mom. I mean, just to be monitoring that and knowing that they have the gene. Just because you have the gene, does that necessarily mean it's going to develop into the condition, Dr. Berenbaum?
So the chance of each kid getting the gene is an independent coin flip, and it's 1 out of 2. And so the chances of all 3 kids having this mutation is 1 out of 8. So, it's unusual that all 3 would carry the mutation. Now, in your kid's case, Andrew manifested disease at a pretty young age.
Yes.
But the girls so far, their echoes remain completely normal.
Because you see all 4 of these family members. Does it have anything to do, I have to ask, that they were triplets? Could they have just been 3 siblings born at different times? Does that have any factors?
They're not, if you can tell from the pictures, these are not
Clearly.
identical triplets. Certainly Andrew is not identical with his sisters, but the sisters are not identical. So they're just, they were born at the same time, but genetically they're the same as kids that were born 2 or 5 years apart. So they're different kids, different genetic draws. They all happen to get this one gene.
So your son has the same ICD as you, is that correct?
Correct. Dr. Berenbaum recommended, he has marked hypertrophy, and Dr. Berenbaum recommended that he get an ICD his senior year of high school before going off to college.
What was that like for him?
So, he basically, he's accepted the disease with grace and makes the best of it. And I did have to pull him from sports and, that he had a love for starting at age 10. And, but no, his first device, I think he was probably relieved like I was. It's a insurance policy and gives you a little peace of mind. And so he had his first implant his senior year, and then most recently he had it replaced, I believe, December of 2022.
So should everyone have this insurance policy? Does everyone qualify to have that?
So we've identified certain risk factors within the HCM population that put you at increased risk for sudden cardiac death. And one of those is a family history of sudden cardiac death. And that means that your risk of an event is in the 2 to 3% per year range. Now, if I tell one of my 92-year-old patients, there's a 3% chance you're going to die this year, that's going to be the best news they've heard in a long time. But when you tell a 20-year-old who's otherwise completely healthy, there's a 3% chance this year, and if we look over the next 15 years, that's a 45% chance. That's
a different story.
That's a very different story. And so that's why the defibrillator comes into play. And you know, it would be nice if we could perfectly identify individuals who will need the device and perfectly identify individuals who don't. We put in more defibrillators than end up being necessary. But there are also patients I have with defibrillators who, you know, it's 10 or 15 years down the line or longer, and they have an event.
So what are the biggest concerns that you have as the disease progresses? What does life look like for someone?
So again, many people can be managed very effectively with medicine. We have new medications to help manage the disease in the past 18 months, which are extremely helpful. We have interventional procedures to thin out that septum. A surgeon can resect some of that. One of my interventional partners, Mark Wiley, does a specialized procedure where you actually occlude a little branch that goes into the septum to cause a little heart attack and turn that thick muscle into a little bit of scar and thin it down so you don't have obstruction. But you know, we send 1 or 2 patients a year for a heart transplant for HCM. And that's out of, I got some numbers yesterday and they came back with a list of 702 patients at our center with HCM.
Well, we want to get your questions answered this morning, so make sure you send those in on YouTube, Facebook, the X platform, and the All Things Heart email. You will find information right there on your screen. Let's get to some questions that are coming in today. Yen Liang wants to know, is traditional surgery necessary for the treatment for hypertrophic cardiomyopathy, or can catheter-based procedures be used?
So both procedures have their role, and again, not everybody with HCM needs either one of those procedures. Those procedures are strictly for patients with obstructive HCM, and that's about 1/3 to 1/2 of patients with HCM. And so some people are technically better suited to one procedure or another. For some people, it's a choice. Most people in the field would consider the septal myectomy, the surgical approach, to be the gold standard, the best therapy if you need an invasive approach. But there are definitely patients who aren't a good candidate for that, and the alcohol septal ablation is a great option.
Has anybody else in your family been tested for this?
Yes, once genetic testing became available and I received the genetic testing, then I'm one of 5, and so my 4 siblings got genetically tested. Of the 4 siblings, 2 of them have the genetic marker, so they then proceeded to get their children tested. My sister has 2 sons that carry the gene, and my brother has 1 son that has the genetic marker.
We mentioned athletes that drop dead suddenly on the court. Could you speak to the case of Hank Gaithers? Is that, I guess that's a somewhat, we talk about, they get a lot of, a lot of spotlight when it's somebody who's famous.
That was a long time ago, and I'm not going to remember enough details to tell you anything about that case.
Okay, fair enough. Okay, I had to ask. How common is this? I mean, you kind of put some numbers into context, but
So it's 1 out of 300 or 400 individuals is diagnosed, has HCM. Now, some of those people aren't diagnosed during their lifetime. Some of them are. So if there's 2 million people in the Kansas City area, That would be about 6,000 patients, and most of those, probably aren't diagnosed or aren't diagnosed correctly.
Last question is, Mark-Ann was told that she needed to come to, or suggested to come to, a center of excellence when it comes to her heart care. Why is that so important?
So, we have an excellent center for all different kinds of heart disease, but in particular, we have a nationally recognized center of excellence for hypertrophic cardiomyopathy care. The average, and we have really 4 cardiologists here that see HCM patients. The average cardiologist sees 3 to 5 patients with HCM, and because there's different kinds of HCM and different presentations, if you see 3 to 5 patients with this disease, you're not going to be comfortable taking care of it, and you're not going to do a great job typically. Not always, but typically. 700 patients split 4 ways. Each of us see hundreds of patients with HCM, and that means that we're much more attuned to what's going on. We have heart failure specialists in our HCM group. I'm an electrophysiologist, so a heart rhythm specialist. We have people who focus on the echo aspects of HCM, the MRI aspects of HCM. We have genetic counselors available.
So what I hear you saying is you really know what you're doing. Very specified.
I think we do, yes.
I think you do too. As we wrap up, Mark-Ann, I want to get final thoughts. What do you want people to take away from your story?
Well, as a patient, I've learned that you have to be your own best advocate, and also that knowledge is power. So when I was diagnosed, I did my research on HCM, and then I discovered the HCMA that evaluates and approves either doctors, hospitals, or clinics to be considered a center of excellence. And so my mission was to find a doctor that's affiliated with the Center of Excellence and that is interested in advancing research of HCM and has an interest in knowledge regarding HCM.
You landed in some good hands here with Dr. Berenbaum. What is your final thought? And I know you got a quick plug you want to sneak in.
So, I think that, again, even now compared to 2 years ago with new drugs available, our ability to treat HCM patients has improved dramatically in the last 2 years and definitely over the course of my career. We are putting on an educational webinar for patients or anyone else who's interested. It's 2 weeks from tonight, I believe at 6:30 p.m. It's a webinar, so it's virtual, you do it from home. You register through the Hypertrophic Cardiomyopathy Association, and their website is 4HCM.org. And if you go there, you will find a link to sign up. And I think everybody in the KU system is going to be getting a text on their phone in the next few days, alerting them to this and letting them know that they can register.
And there is the website right there on your screen, a great opportunity to learn a whole lot more than and expand this conversation. So thank you both for being here, but we got one more thing that we got to take care of for you, because we love to show the incredible work of our doctors here at the health system, but we also like to show what life looks like for them outside of the hospital walls.
Now for a secret look into the guardians of healthcare at the University of Kansas Health System. Let's go behind the mask.
All right, Dr. Berenbaum, tell us about these cute kids in the pictures.
I have 8 grandkids, 3 kids, 8 grandkids. My wife is a redhead. We had 3 kids with very dark hair, but she has 2 redheaded grandchildren. Which is particularly exciting for her, and they're a lot of fun, And I just came back from a few days in Chicago, visiting the 3 that are in Chicago.
Did they run you around? Do you feel rested or like you need to rest up a bit?
I came home to go back to work and rest.
Exactly. That's a good way of putting it. Well, thank you for sharing those photos. And again, Mark-Ann, thank you for being willing to share your story with us today.
Absolutely.
We learned a lot. So next week on All Things Heart, before he even turned 50, Doug Lewis faced 2 major medical emergencies. See the unlikely hero he credits for saving his life. And here's a hint. She's much too small for scrubs. That's next Thursday at 8. Coming up tomorrow on the Morning Medical Update. Stroke care is improving, but can it keep up with the aging population? I'm Jessica Lovell on the next Morning Medical Update. The growing burden of stroke. See the enormous impact on caretakers and what needs to improve to better care for baby boomers. Friday at 8.